Hello, I'm Dr. Youssef. I'm going to present to you today the routine case of cataract extraction, how we do it in 2022. So I start by opening the main incision with a 2.75 millimeter incision, self-sealing. That should be long enough, and the construction of that one, it should be really self-sealing. This is the Xylocaine 1% preservative-free, mixed with phenol 10. And I use Indicoat to protect the cornea from the back and front and fill the chamber. I cover the cornea very well so that the nurse doesn't need to score the cornea throughout the surgery. And then I create a paracentesis 80 degrees to the left of the main incision. And it should be small enough just to allow the second instrument you can use a chopper throughout the surgery. I mark the rhexis. This is a mark of to give me a rhexis of 5 millimeter. I start the rhexis in the middle and push outwards to where the mark was, and just go around using the Utrata forceps. Keep capturing the capsule and just drag it into the middle of the pupil, so that it doesn't get dragged in with the viscoelastic coming out of the wound. Sometimes it can drag and pull out. I'm doing the hydrosection, hydrodelineation, nuclear rotation. This step is important because it will make everything else easier afterwards. So we use the Signature Pro, the J&J phaco machine. This is an unedited video, so that's why there's a gap here. I use the chopping technique. So this is the universal chopper. It's very effective. Most of my action is in the middle of the pupil, so the phaco is done middle of pupil and pupil plane. I try to keep the epinucleus as much as I can inside, keeping the capsule and protecting the capsule. So you see the nucleus, the epinucleus, push it back again so that it's protecting the capsule. I like to remove it as a separate layer. So the nucleus is removed now, the epinucleus. I always protect the capsule with the chopper underneath the phaco tip, so it doesn't capture the capsule. Now I use the J cannula. I have a separate video for how to use it, but you go in, go to the right side, and there's a gap there, so you can actually go there and push as a secondary hydrosection. So it's very similar to the first hydrosection, but now there is no nucleus or epinucleus, so everything comes out in one piece here in a few seconds, and it's done and clean. And you clean the capsule safely, effectively, without risking the capsule being captured. Always in and out from the eye, you put the J cannula horizontal so it doesn't capture the wound or anything else. I use heel on here to inflate the capsular bag. This is a preloaded J&J intraocular lens, DI-BOO. I always measure the or check the white to white diameter, because sometimes when you do that step and you're not sure if the size of the eye is small, it can actually open the capsule using the lens if it's too small. So I usually check the white to white diameter. Now I do coaxial IA using the lens as a shield, so I don't come close to the capsules with the IA. J cannula did the job of doing the cortical cleanup. Now I'm using the 10 cc on a hydrosection cannula to position the lens, clean up behind the lens. I don't go with the IA behind the lens. I just do that irrigation without aspiration, and everything comes back out of the wound. I hydrate the wound and fill the chamber with moxifloxacin. So this is the moxifloxacin hydrating the wound. It looks very white now, but in a few minutes it's gone. But it shows me where the hydration is happening, and it's very effective to prevent endophthalmitis. I replace almost the entire content of the inside of the anterior chamber with antibiotic, and I do the bilateral surgery, and this is the dropless injection, a mix of moxifloxacin and triamcinolone.